Welcome to my presentation on ultrasound physics. My name is Amy Barnes and I'm a sonographer working in the University Hospitals of Leicester. Before we begin, I'll just give you a little bit of background about myself. So I completed my postgraduate diploma in medical ultrasound in 2008, where I spent years perfecting skills in ultrasound of the abdomen, gynecology, obstetrics and early pregnancy. After that, about 6 years ago, I specialised in head and neck ultrasound through an in-house training programme using the Royal College of Radiologists ultrasound training recommendations, which includes me performing ultrasound guided biopsies in the neck. I have become an accredited advanced practitioner by the College and Society of Radiographers. I'm also a clinical lead for the department. So I'm not a physicist, but I do have lots of ultrasound experience. So I'm an advocate for ultrasound. I see it firsthand every day that it is a strong imaging modality. It works really well with cross-sectional imaging, but also can stand alone independently as a diagnostic tool itself or in surveillance for patients. It has many advantages, which we'll go through in a minute, but I think one of the main things is the instant reassurance that it can give to patients. So the advantages of ultrasound mainly is it being non-ionising radiation modality, unlike plain film and CT. Therefore, it's ideal for imaging radiosensitive regions such as gonads, the thyroid, and can be used in assessing fetal development even from the first trimester. There are no adverse effects by metallic objects, such as is the case with CT and MRI. And in fact, there's very few, if any, contraindications apart from the heating of tissue, which can happen at high frequencies with prolonged exposure in one area. However, this isn't usually a problem because of the dynamic nature of the ultrasound examination. Ultrasound is widely available and available in most centres with multiple machines in some of the bigger trusts. Less expensive, obviously, than CT or MRI. And again, as I said, the real-time nature is useful for evaluating physiology as well as anatomy. So it can be used in echocardiography, assessing fetal heart, imaging, and also needle placement for biopsies. The examination can be easily extended. So if you are scanning the testes and find a hydrocele, you would expect the operator to extend the examination and actually look at the renal tract as well. Moving on to the main disadvantage to ultrasound is operator dependency. So training and using the machine, manipulating the controls and interpreting the image is essential to achieve accuracy, but also reproducibility, which is key in assessing quality. So if a patient was scanned for gallstones 1 week and it's a negative test, shouldn't be able to have a different operator the next week who finds gallstones. Obviously, there's areas of ultrasound, there's areas that ultrasound can't evaluate, no matter how experienced the operator. So thermal heating we went through on the previous slide, so I won't go back over that. So ultrasound has unique artefacts which can lead to misinterpretation for reasons that will become apparent later on in the presentation. Body habitus, so large body habitus. So the quality of ultrasound images are degraded with increasing depth again, which will become much clearer later on in the presentation. So I think before we start, it's a good time to tell you that this topic won't be forming part of your assessment. However, it would be really great for you to be able to understand the basic principles and physics of ultrasound before you get some hands-on experience. The aims of the presentation are to understand some basic ultrasound physics principles, to be able to use the machine, or at least understand which buttons and controls we need to be able to use to manipulate the image, artifacts that can happen and how they can be interpreted and misinterpreted, Doppler, elastography as an advanced technique, and then we'll round it up with some take-home points. How is the image produced? So for this we will look at the ultrasound system, including the machine and transducer, the physics of the principles that produce the image, and what's happening to the ultrasound beam inside the tissue. So to begin with, the correct ultrasound transducer type is key to the performance of your scan. These are the transducers or probes that are available in most departments. They're all different in shape, size, with varying features. So picking the right one for the right job is really important. So as we've said, ultrasound is dependent on interpretation and manipulation of the image as and when necessary. But before we go into that, we need to know how the image is produced. So this is a static ultrasound machine. I think one of the benefits of ultrasound is its simplicity. You don't need very much, your machine and your probe and a patient. Portable machines are even smaller than this and can be used and really transportable, so it can be used around the hospital, patient bedsides, within clinics, theatres. So long as you've got a plug, you're good to go. So the current is applied to the crystals in a transducer. These crystals rapidly expand and contract, forming vibrations in the form of sound waves. This is the transmit signal, which propagates through the tissue. The signal is reflected back to the transducer as the receive signal. The crystals deform again by rapidly expanding and contracting. And this generates an electric current which is sent back to the machine, where the corresponding image is created by interpreting a signal which is in terms of depth and density. We'll go into how we see that and what we can do about it later on, but that's the big picture of how the machine produces the image along with the transducer. But what we need to do now is have a look at the transducer in a bit more detail and how it works its magic, which is otherwise known as the piezoelectric effect. So we have already established that the crystals, or collectively the piezoelectric element, vibrates and produces a transmit-receive signal. This, however, isn't constant. The crystals transmit a brief pulse of sound and then pauses to listen for the receive or reflected signal. This is called the pulse repetition interval, or PRI. The number of pulses and pauses per second is called the pulse repetition frequency, or PRF. This pulse pause allows the machine to calculate how long each echo takes and therefore interprets this as depth. There can be some miscalculation of this, which we'll talk about in the artifacts part of the presentation. So we also know that ultrasound is seen in real time. So how does this happen? Well, each crystal produces a scan line. The ultrasound beam is a collection of scan lines, and these all work together to see movements. The transducer is then swept across the area of interest, and still pictures can be captured by freezing the image. So if we want to be able to understand what we're seeing on the screen, we need to be able to understand what these four physics principles are. So amplitude in audible sound would be referred to as the loudness or the strength of the signal. It's measured in decibels. The higher the amplitude of the transmitted signal, the higher the amplitude of the return signal. The return signal is assigned a pixel value, which is displayed on the screen. So the higher the amplitude, the brighter the image. Frequency is the number of cycles or hertz per second. The frequency range in ultrasound is in the million or megahertz. Simply, the more cycles per second, the higher the frequency. Wavelength is the distance between the crest or trough, in this case that I've marked, and is inversely proportional to the frequency. So the higher the frequency, the shorter the wavelength, or the lower the frequency, the longer the wavelength. We'll look at this in practice on the next slide. So the last one is velocity. Velocity is speed and direction. This is proportional to the density of the tissue it travels through. So most tissues, soft tissues, have a similar density. therefore will have a similar velocity. Air, however, has a low density, so does not transmit ultrasound, which is why we need to use the gel between the probe and the patient to get rid of the air gap. So the next time the patient asks why you have to use the gel, you can just tell them it's all about velocity. So if we go back to the relationship between frequency and wavelength, we find ourselves with an inherent and constant trade-off, which the operator needs to be fully aware of. This inescapable trade-off is penetration or depth reached versus image quality. If we go back to the disadvantages, you'll remember that an increased body habitus was one of them. So to image this patient, we would need a low frequency with a longer wavelength. This signal will interact with fewer molecules on the way through the tissue to achieve this penetration, but will result in poorer image quality or resolution. Whereas a higher frequency signal with a shorter wavelength will interact with more molecules, giving us a better image quality, but only to a limited depth. The signal is received back to the transducer due to reflection. The amount of reflection is dependent on acoustic impedance between the tissues, and acoustic impedance is a product of tissue density and signal velocity. So the bigger the difference between the tissue density, the more signal that is reflected and the brighter the echogenicity. So we can see on the image here that the parenchyma of both the liver and the kidney is quite similar, but what we can see is the brighter reflection or more reflection, so the brighter the image of the fascia of the kidney. And if we can direct the sound beam perpendicular to that, we will increase or improve our image quality. So as the ultrasound wave propagates through the tissue, the signal strength degrades or becomes attenuated. The degree of attenuation will depend on frequency and the depth. So this is true of audible sound. So the further away you are from the sound, the harder it is to hear, and this is true of ultrasound as well. So where does the signal go? So we've already talked about reflection. Most of the sound echoes back to the ultrasound probe, but there is a degree of signal loss. Absorption occurs when ultrasound waves interact with molecules in the tissue, and this is converted to heat, which is responsible for some signal loss also. And scattering, this sends waves into all different directions, and very little is reflected back to the transducer. So the higher the frequency of the ultrasound wave, the more attenuation, therefore, as we've discussed before, the less penetration. So let's just recap. When we look at this ultrasound image, what do we know? So we know the stronger the signal, the brighter the image. Brighter echoes on ultrasound are referred to as hyperechoic, darker echoes are referred to as hypoechoic. Frequency and wavelength are inversely proportional, so the higher the frequency means good image resolution, but we can't see very far, so we struggle with depth. The lower the frequency means that we can see deeper structures, but we compromise on image quality. We receive the sound waves back to the transducer due to reflection, but in the process we lose signal to absorption and scatter. So next we're going to go and have a look at how we can manipulate the image with the controls. Unlike some other imaging modalities, ultrasound is extremely user dependent, as we've said. The quality of the images obtained will depend a great deal on the technique used to obtain them. An important part of image optimization is developing a familiarity with the control panel of the ultrasound machine. So that's what we'll look at next. To be able to drive the machine and manipulate the image as you want it, you need to know about depth, focus, time gain, compensation, and overall gain. And we'll also look at harmonics. Overall gain is an increase in amplitude of the return signal expressed on the screen as brightness. Turning up the gain will make the whole image brighter, and this can allow for better visualization, as you can see with this kidney. However, if you turn it up too bright, then it can white out areas of interest. time gain compensation is controlled usually by a vertical row of toggles. Time gain compensation allows for the gain to be adjusted differently at different depths. So if you remember that the depth is determined by the time it takes for the signal to return to the transducer, which is why it's called time gain compensation. Hence the amount of gain in the near field might be decreased to darken the area of soft tissue, while increasing the gain in the far field to brighten up deeper structures. The focal point of an ultrasound signal is the narrowest part of the beam. This can be adjusted and it will improve the resolution of the signal at that point. So the focus is depicted here by the white line or bar on the very right hand side of the screen. And you can see, ignoring the Doppler box, that in the right hand side image you can see much clearer the anterior part of this liver lesion than you can on the left hand side screen image. So adjusting the depth will make the deeper structures appear clearer and more defined to a point. But I just wanted to make you aware not to use it to make kind of pretty pictures by getting rid of the far field or the blurry part of the image, because it's really easy to miss pathology. And I've tried to show on this slide that you would miss the tail of pancreas if you had your depth too low. So if you had something like a 5 centimeter depth instead of an 11 centimeter depth, just to get rid of that back part of the image, you could easily miss a lesion in the pancreatic tail. Harmonics is a feature on newer ultrasound machines, and it tackles the issue between penetration and resolution. So harmonics are created when an ultrasound signal interacts with molecules in the tissue, causing them to vibrate. The vibrations include the original signal and multiples of the original signal, and these multiples are the harmonics. All frequencies are reflected back to the transducer. The original frequencies are subtracted, leaving only the higher harmonic frequencies. Therefore, we can use a low frequency sound, get good penetration, and at the same time see only the high frequency echoes, which improves our resolution. This means that scanning patients with larger body habitus is no longer a disadvantage. So harmonic imaging offers huge benefits and really improves the quality of the images we can produce. It's associated with fewer artifacts than conventional ultrasound. Disadvantages include accuracy of measurements and also clearing up artifacts that can represent beneficial information, and we'll look at that when we go to artifacts in the next few slides. We've said that harmonic imaging reduces artifacts, but we still need to know what they are because we'll still see them and they can be useful in our image interpretation. Reverberation occurs when the ultrasound beam bounces back and forth between two strong interfaces. Because each trip takes longer than the original, it's interpreted as twice as far away. This results in a set of false echoes. In this image, the reverberation artifact behind the intrauterine contraceptive device, which clearly in this patient hasn't worked. It can also happen behind biopsy needles, surgical clips, and foreign bodies. It's most obvious when the object is perpendicular to the transducer. Comet tail is a type of reverberation and can be seen here behind a benign colloid thyroid nodule. This has clinical significance because it differentiates hyperechoic foci from microcalcification, which is a sensitive and specific feature of papillary thyroid cancer. Comet tail artifact can also be seen in adenomyomatosis of the gallbladder. Acoustic enhancement happens when there is less acoustic attenuation through a structure than the surrounding structure. The deeper tissue, therefore, is overly bright because the fluid is an efficient transmitter of the ultrasound. It's most common behind fluid-filled structures, like this image of a urinary bladder. If it's unrecognised, it can lead to adjacent structures looking darker and being misinterpreted as free fluid, especially in the abdomen. There's also a scenario where this happens behind a solid structure. It's called pseudocystic and is common in appearance of lymph nodes in patient with lymphoma or a pleomorphic adenoma of the parotid gland. The opposite to this is acoustic shadow. This shadowing occurs behind structures that are particularly dense and therefore there's no return signal behind them. As shown here, behind a gallstone or multiple gallstones, without the shadowing or with subtle posterior shadow, solitary gallstones can be misinterpreted as a gallbladder mass. It can also happen, well, it does also happen behind the ribs when you're scanning the liver. Mirror image, this can be really subtle, and it happens at a smooth boundary that is curved rather than flat. And because of the curve, the ultrasound is reflected in various directions before returning to the transducer. Because the reflections take longer to get back, they're assumed to be further away. So what's happening here is you can see the diaphragm, because the lungs behind are poor attenuation, are poor transmitters, therefore there's hardly any signal, returning signal from the lungs. So what you see here is actually a mirror image from the liver and not lung tissue. So caution should be taken here because abdominal ascites can be misinterpreted as pleural effusion when actually it's a mirror image from the fluid in the abdominal cavity. There's different types of Doppler, but for this slide and this presentation we're going to concentrate on colour flow Doppler. So Doppler can be used to assess or to measure velocity of blood flow. Colour flow Doppler is a pulsed wave signal with a colour value assigned to the received signal, which is superimposed onto a 2D image, which you can see on the screen there. So Doppler shift is the change in frequency between the original signal and the return signal. So if we had a stationary object, it will reflect the original signal at the same frequency at which it was sent, whereas an object in motion relative to the transducer will reflect a signal back with a different frequency. So if the object is moving towards the transducer, the return frequency will increase, and that is expressed in red. If it's moving away from the transducer, it will decrease in frequency, and that is expressed as blue. So just to note, because it's commonly assumed, but the colour scheme has no connection to arterial and venous blood flow. It is because it's moving either towards the transducer with a high frequency or moving away from the transducer with a low frequency. And the colour can actually be interchangeable. So the magnitude of that change is the Doppler shift. Conversely to two-dimensional ultrasound, which we've been talking about, when using Doppler, a lower frequency transducer is better to assess a high velocity blood flow, and it is best to have the transducer parallel to the blood flow rather than perpendicular, as we were saying earlier. I also just wanted to mention aliasing, which is an artifact that is particular to Doppler. It happens when a maximum velocity is exceeded, and factors that cause it are a high frequency transducer, inappropriate angle of the transducer or the beam, and a large sampling volume. So you just see that the colour flow is mixed between red and blue. Elastography is a relatively new technique that's based on the fact that a pathological process alters the elastic properties of tissue. For example, a cancerous tumour would be harder than the surrounding tissue, or a diseased liver would be harder than healthy tissue. It can be utilised in breast ultrasound, thyroid nodules, and in the liver. It's, like I say, relatively new. It's still being developed for clinical use, and improvements are still necessary for reliable clinical diagnosis. But there are two ways that it can be used in ultrasound. The first one is strain elastography, and this involves adding an external or manual compression to the tissue, which is good for the thyroid because it's so superficial and you can get that compression of the gland. Obviously not so good for the liver. So you would use a shear wave elastography, and the compression or push is induced deep into the tissue by a high intensity pulse through the probe, so it's not manual, it's done automatically. The UHL has been part of a national study for the use of elastography in thyroid cancer. Findings are still to be published, and I doubt elastography will replace any part of two-dimensional ultrasound, but the outcomes will be interesting, and hopefully it can be used alongside the features of 2D ultrasound to help us improve patient outcomes. Well, that's ultrasound physics, a bit dry, but hopefully you have gained some understanding. Manipulating the controls and understanding the effects of what we've talked about is much easier when you're in front of the machine. Ultrasound has limitations, like all imaging modalities. Some have been overcome by technology, which I'm sure will keep improving. Ultrasound is a great diagnostic tool and shouldn't be underestimated, and the best way to learn it is to practice. Thanks for listening.